Um, well, hey everybody, thanks for coming to XPC Talks. Today we're gonna talk and learn from Karim Hanna, who's launched a family medicine residency program. Like that's a crazy thing to pull off. And I'm wearing my family medicine t-shirt in honor of this event. Represent. That's right. Okay, so Karim, I'll hand this over to you. Tell us a bit about yourself, and then I know you prepared some slides, and then we can kind of, if you want people to interrupt you, let us know.
Yeah.
Otherwise, people can put questions in chat, and we'll keep it casual.
Yeah, please feel free to interrupt me. I'll share some slides. I've got about 20 slides, and we'll try to be done by 12:45, so we can, or even less than that, probably 12:40, and we'll try to kind of open it up for more conversation at the end. Hopefully, it's fruitful for everybody. I'm Karim. I'll tell you who I am in a second, but I'm at the University of South Florida in Tampa, and kind of long-time listener, first-time caller, like with XPC, first time kind of jumping to get to speak with you all, but excited to be here. So here are my slides, and this is supposed to be kind of low stakes, kind of pretty casual. So cut me off, ask me questions, and hopefully we can all walk away with something from this. I think building in general is pretty cool, and all of you have probably built something in some capacity. You may never build a family medicine residency, and in that sense, this may be completely irrelevant to you. But if you're building anything, there are hopefully some take-home points from this talk. And one thing I was thankful to Polyus for is this is the first time I've actually been able to look back and reflect on this whole experience. I've been going at this now for about 3 years, since 2022. So here we go. Let's jump in. So I always like to start with my why. And if you're not familiar with this book or the TED Talk, I think it's like the most watched TED Talk ever. Start with why. You should watch it. Simon Sinek is a pretty cool brain to get into. But my why did I get involved in medicine? Why did I get involved in informatics? Why did I get involved in building a residency program or sign up really for a job in academia at all after residency? You don't necessarily need to know all the answers from the very beginning, but at the core of your why, that's going to kind of keep your flame going, or that's going to spark everything moving forward. And it might be a different why for the later asks or the later tasks that you're given. But for me, it's really about serving others. And that's really the initiative for a lot of my decisions. How can I serve others? And we're here, hopefully, so you can take something home and serve others and pay it forward. And this, like I mentioned, it was my opportunity to kind of reflect. These are my 6 words, right? I'm a husband, father, physician, teacher, informaticist, and a musician. So I'd love for you guys to kind of throw in the chat your 6 words. Like, who are you? Tell me in 5 or 6 words, who are you? And I know, obviously, some of you already, but this is kind of one of my favorite prompts, is to kind of squeeze them in as much as you can. Give me your 5-word or 6-word description in the chat.
What kind of musician are you? I didn't actually know that.
Great question. I grew up kind of a piano dropout, right? So my dad's a musician. His dad was a music teacher. And now I own probably like 17 instruments in my house. And I mess around with all of them. I'm not super good at any of them. My favorite instrument is the oud, which is an Egyptian or like Middle Eastern kind of, it's kind of like a lute, fretless guitar, curved back, double strings. And yeah, I mess around. I play mostly by ear. Don't really read notes anymore. That's my music interest.
Amazing. Like I have a daughter, she's 7 years old. I try so hard for her to learn one like piano.
That's good. That's good. Piano is a good place to start. I think it's probably the one of the most important places to start, because you get a basic understanding of just how music works. But yeah, Matt jumped in first. Thank you. I like that you describe yourself as creative first. I think that's very, very important. And I know you're a foodie already.
If anyone's followed the Instagram, for sure.
Fantastic. Yes. Lovely. Lovely. Awesome, Robbie. Blood and
Yeah,
coffee.
mine mirrors yours quite a lot, actually.
Blood and coffee.
But I don't play the oud. I used to play the derbeki actually, like on
Yeah.
like pretty well, but arthritis in my hands, so I
Well,
can't do that.
we'll have to get together. I have one at home, so if you're ever in Tampa.
Yeah.
Lovely, lovely. Humin and Tawheed, thank you guys for your comments as well. All right. Catan second placer. That's hilarious. All right. So the why for our department, just to give you a little bit of the landscape, I'm in an academic center. Our department has right now about 18 providers outside of the kind of private practice people within our health system. So I'm in an academic job, about 50-50 split between teaching responsibilities and administrative stuff and seeing patients. And we're here to kind of address health disparities and serve our community. But what happens is serving your community doesn't always pay the bills and keep the lights on. So over the years, our department that started in the 70s, I think, has kind of shifted to really a private payer, upper middle class clientele for our patient population. And our, dean and our chair and stuff, of like maybe 5 or 6 years ago, started to have reigniting the conversation surrounding, our health disparities, our community surrounding our clinic. And I'll show you a little bit more about that. But that just gives you a little bit of the background. And we wanted to establish a second residency. Our first residency, I'll show you in a picture, has been going on for a long time. It's just really far away from where our academic practice is. It's a standalone hospital. If you know anything about family medicine training, oftentimes residencies are at standalone community hospitals. That's how I trained. We were the only residents in the hospital, and it was a smaller community hospital. We were hoping to establish a second program at our big, 1,300 bed, every subspecialty you can think of at TGH Tampa General. And we wanted to serve specifically the zip codes around our community, and I'll show you why in a second, but our community's outcomes were pretty poor compared to the rest of the county here. And we know that zip code can tell you a whole lot about health outcomes. And Hillsborough County in general was not great compared to the rest of Florida. And Florida, as some of you may know, is in general not great compared to the rest of the country. So this was kind of the why of our initial push for this sort of lift. We understood that it would be a large lift. A lot of change has happened and is happening in our department, but we recognize kind of the value of serving our community in this way. And oftentimes, getting patients, it's really hard for you to take the 18 providers and say, okay, well, we're just going to add a whole load of other patients who are under or uninsured, for example, or who are really struggling with X, Y, or Z. But this was a quick way to add a lot of providers, 24 residents in our case, and in a short amount of time in order to serve that population better. This is where we are on the map. And in between kind of the left and the right of your screen, you see two major highways that go through Tampa. I-75 goes all the way up the East Coast, and 275 is like a local highway. And this area is often called Suitcase City, where our clinics are. And again, it's kind of an impoverished part of town that really struggles. And this was one of our first original pitches. I took this slide from a slide very early on. You see the darker orange. We have poorer health outcomes in these particular zip codes where our clinic is compared to those around us. And these are all publicly available through the Department of Health or through the state. But regarding diabetes, hospitalizations for diabetes and cancer diagnoses and earlier death, like life expectancy in these counties was worse than those around us. So we knew we have some work to do in our local area. You see the drive from our clinic to Clearwater Beach, where our current first residency program is. That's about 48 minutes and not really sustainable for us to have really a true relationship with our community, with those residents, hence the need for adding the second. And where you see all my starred locations, that's where Tampa General is. Tampa General lives on an island, literally, which is not exactly the best place, again, to reach our community where we're at up in North Tampa for our campus. This is Tampa General, just showing you that it is an island, like you have to cross a bridge to get to the hospital, which isn't ideal in hurricane situations. But it's, it is what it is. It's what we've got. This is our academic health center, and our medical school is just across the street in downtown Tampa now as well. A big part of my job, as we were kind of laying the beginning foundations in 2022 when I first got the role, was, Karim, you have to build relationship. And you have to connect with folks, and you have to build people, build relationships with people, so that you're not building this alone. And this has been a very, very pleasant experience. Labor intensive, I think, with just the sheer number of meetings, especially early on. But very nice to see how many people are actually willing to help you out if you just ask. So countless meetings, lots of presentations, pitching to people, asking for their help, showing them the value that we're hoping to bring to the organization. And then certain collaborations in whatever you're doing are definitely really important at the start and just kind of happen coincidentally. So our internal medicine program is huge, 35 residents per year, plus all the fellowships, and stuff like that. So it's very large footprint, and they cover 3 hospitals in the area. So our partnership with them is pretty crucial, because we don't have the bandwidth to have a 24/7 service, especially nights and weekends and stuff, with just our 8 residents. So coincidentally, during COVID, when they were, really in the trenches, they asked for our help to support them on internal medicine services. And that kind of started to build a really nice relationship interdepartmentally. So we got to know all of their hospitalists really well, and we started, working with them on their hospitalist service, which again laid a foundation that really we weren't planning on doing in 2020 when this all took place. So some of the stuff, as you're building things, will happen coincidentally, and there are relationships that you already have that are very important for you to keep and to feed into. Then the opposite is also true. There are certain people who need the program to succeed, and those who want to make it happen. And some people, you might be surprised, maybe don't have the reaction that you'd anticipate. You go into a meeting with your hospital CEO, and I was covering our inpatient service that around that time, and I kind of went into a meeting asking for the support of the hospital to build this program, and we eventually got the support. But I was coming in from an angle of like, hey, our ERs are super overwhelmed. There are people on beds in the hallway. We should, really improve our outpatient care to prevent them from coming in. And we kind of got an interesting reaction from the hospital CEO. But his stance was that the hospital actually doesn't need to decrease ER admissions or visits. And after that conversation, it was kind of awkward, right? I'm saying I'm going to solve a problem, but you don't necessarily see it as a problem. After that conversation, my eyes were open that the hospital doesn't necessarily want decreased ER visits from a financial perspective, or decreased hospitalizations from a financial perspective. So then you have to come at it from a different value add for the people that you're meeting, and recognizing what is important to them so that I can make it important in my kind of take home points. That was very eye-opening for me, kind of like jarring. I was like, what do you mean? How would we want more people? Why would we want more people in the hospital? But it's important for us to keep in mind.
Yeah, and Karim, I would almost add, just like this is a theme I feel like is very true across everything, is like you're set up to get jaded very fast once you start building, because like things get very real very fast, which is, it's kind of fascinating to hear that you were finding this out even like this like late stage in your career, right? I mean, you're mid-career, but like still like that's just a fascinating example.
Yeah, it was very eye-opening. One of my mentors in residency, I was like talking to him about career goals, and he's like, yeah, my goal is to build such good primary care that hospitals have to close down, right? So that was like really kind of a big, I don't know, like key memory for me in training, like that's how good we should be in primary care. But obviously not everyone sees it that way. It's not the way to go. I see some stuff is going on in the chat. I'll check it out later, Evan, for sure. But I'm not sure what that is, but I'll take a look at it later.
No, just to echo your great point. So
yeah,
just kind of add some greater stories to it. So definitely hear you on that. Appreciate it.
Someone else was chiming in too.
Yeah, I really find this to be really interesting, especially with a family medicine background. I think sometimes we find ourselves not fully aligning with what a hospital institution has in mind. Did you, in your discussions with like administration, was there any talk of like, hey, we are planning for how our billing model is going to change? Like value-based care is something that we're thinking about. Is that something like that's may or may not happen? And so what you're doing is not exactly what we're thinking about. Like, what did value-based care ever come up in these conversations? I guess
value-based care did come up, and fortunately or unfortunately, our institution is already so big that we've got value-based contracts with some of the kind of, we're part of a very large ACO for some of our payers. So we've already kind of had those conversations, but at the same time, I'll speak on the medical school side of things, right? Our dean is currently an OBGYN and values primary care because in his experience, primary care was important. But when you're in like the medical executive committee meetings for the hospital, and they're talking about how this month we only made $15 million or $30 million, and last year, same month, we made 34. Our surgical volumes are down. That's always the first line that they say. Our surgical volumes are down. At some point, it's business and it's numbers, and it comes down to bottom line. So they may not see the value because of their lack of experience, or maybe a jaded experience or an altered experience from where I'm coming at. And to everyone's point, I guess we have to find what it is that they value. If they value value-based care, or if they think that's an important piece, then I should come. And I guess primary care being or family medicine in particular, being the kind of flexible thing that it is, we should be able to leverage different aspects of what we provide for our listeners, for those who are kind of listening in or who we're trying to appeal to. But yeah, this was an interesting stage, and I felt like I would have the same meeting like 3 or 4 times before things would actually start to move. So I think I met with the CEO and his whole team, maybe 12 people in the meeting, maybe 3 or 4 times before, okay, let's have a plan of action. We've got the dean's support. We've got the CEO support. Okay, now who else do we need to like get their stamp of approval before we can actually start to build this thing?
So did you like bring backup, or was it like 12 on 1?
No. I certainly had backup, including my chair. Our dean kind of was really on our side, going to the hospital CEO about this. And because Tampa General had such a large GME footprint, I mean, we've got like over 1,000 residents, like of all of our programs. So it's a very large institution. Our dean of GME was also involved in these conversations. So she kind of recognizes the ins and outs of all of these conversations. And financially, it's beneficial for them to start a new program. They just had to see that. Our hospital is a rural referral center, which for those of you that don't know, is a backdoor way of getting constant additional funds for GME spots. Getting CMS funding, I wasn't really planning on talking about that this meeting, but it's a complicated thing. And when a hospital starts GME, they have a timeline of just 5 years to add as many residents as they can. But our hospital, being its size and its location, has this like exception. So they get about $100,000 per resident per year for all the hours worked. Plus, they get $100,000 per resident per year for the first 3 years as startup funds. So they're getting $2.4 million just to start the program, plus perpetually enough to cover their fringe and benefits for the resident. And then they're making on top of it what they're keeping in their pocket, plus all of what the residents are assisting in the care. So there's definitely a financial benefit. That's why you see players like HCA growing at such a crazy rate, adding GME, and now HCA, I believe, is the largest GME hospital system in the country right now. So lots to talk about. Maybe that's a different conversation, GME funding stuff. But
Karim,
yeah.
I just saw that. So you sounds like you did your medical school and undergrad at USF.
Yeah.
So
Yeah.
you've been there for a long time. When did you kind of see a vision for I want to make a residency program?
That's a good question.
And also, do you think, what challenges do you think you might have? I'm just curious how much more difficult might this have been if you didn't have those roots starting
Fantastic question. Fantastic question.
There.
So the first question, did I see the need for it? Probably not so much as a medical student, but when I first got here, it was like a kind of said between the lines, like, why don't we have a residency here? When I got here as faculty, why don't we have a residency program here? And it had been talked about 20 to 25 years ago. There was a gentleman who was on faculty here. He has since passed away, but he was the first person to say, okay, let's make this happen. And he actually had books stamped USF Family Medicine Residency, like ready, they had taken the steps, but at the time, the dean was not very supportive. And you need kind of everyone on board. The dean was not supportive of primary care. And deans really can swing one way versus another on their view of support of different departments. Some deans want to close down family medicine departments and make it like a primary care kind of generic department. And some are very supportive of FM. So it really just depends on the times, similar to kind of political climates. You get climates within institutions and within schools. The second question that you asked, did it help me? I think so, because all the people that I was talking to were all my teachers and they all knew me. So it's like, hey, so-and-so, I was your student on pediatrics 4 years ago or 7 years ago. Can you help me kind of build this thing? So it's been very fruitful, I think, for me. It probably would be more complicated if I didn't know all the people. So then you have, after you've decided and you've gotten everyone's thumbs up, you go to the ACGME and you say, hey, I want to build a program to expand GME. And they say, sure, but there are lots and lots of check boxes to make sure are in place. And I mean, this is like a 60-page application that was really, really complicated. And then you have a virtual site visit. Since COVID, they've been doing virtual site visits, which is really stressful. And frankly, when we came out of that, I didn't think we did so hot. And what they did there was they took my core faculty, met with them separately. They met with my chair, met with me and our dean, all in separate meetings. And then they met with me again at the end of the day. And they kind of make sure that everyone's on the same page, like who's responsible for what and what are the pieces that make this puzzle come together. This was eye-opening. We definitely had a strength in our team and our faculty and our sites because we were not brand new to teaching. All of these people that I've pulled into my faculty, my core faculty, all of them have kind of a whole career built on an academic clinical position. So we're not new to teaching. We've got an old GME kind of place. So the other pieces that we're missing were pretty easy to chip in. But we did really well, actually, and we got lots of positive feedback. And we had to anticipate what it was that they would be asking us, and our deans helped us do those things. The ACGME, for those of you that don't know, is the accreditation body that gives the thumbs up for a residency program across specialties, right?
And were they just mean or was it like the food inspector visit or were they trying to really work with you type of thing? And
no, they were definitely an inspector. They had a checklist of questions, and if I couldn't answer it in a very straightforward way, they would ask it again and make sure that I really didn't answer the question correctly. And most of this was numbers, how many toenails did you remove last year in your clinic? Are you really going to be able to teach toenail removals in your clinic for your residents? Why and why not? And they wanted these really minute minutia of the data. And really, I was not very well prepared on that front. And that was kind of a surprise for that meeting. So I did have some kind of like follow-up points, and they asked us to follow up on them. One of the other things was our pediatric numbers were not enough, and we had to address that by hiring a pediatrician. So I hired a full-time pediatrician in our clinic to really grow our numbers, because our residents need to have certain percentages of their time with different age groups. One thing, but in response to that we really kind of have run with since then, is that our residents really are going to have ownership of their panel, and I'll talk about that later too. But hopefully, we're able to provide for them what they need in those regards. So it's eye-opening also too. It was helpful for me with them being in that kind of strict approach to dotting all the I's and crossing all the T's. Recruitment was then the next challenge. It's like, how do you convince someone to sign up with you for 3 years if you've never had a program before? And I think Paulius and many of you have maybe seen a lot about this online, but the match for family medicine this year kind of dropped, and the interest in family medicine is dropping, and the numbers don't look in our favor. And we are a rather large specialty. I think the second largest number of residency programs to internal medicine. But recruitment is a challenge. And it's the match cycle never stops. So once you finish one recruitment cycle, you're starting on the next. And since we kind of had all hands on deck, we really poured into our recruitment. We did something kind of radical in that we made all of our interviews only in person. And we thought this would be kind of a way for us to showcase our place, our physical kind of like our clinic space and our hospital, and our team much better than just online. And I think if people ask me now, so we filled, right, which is was a big deal, I guess, this year. And it was a really big deal because we were a first year program filling. And a lot of my kind of PDs told me, Karim, I'm surprised. I thought you would not fill, given kind of the atmosphere and the environment and being a new program. But we were fortunate to fill. I think if people ask me, I say, because we made the in-person interview a thing. People had to come, had to show us commitment to Tampa, which was very helpful, because as you see, we invited 140 interview invites, and 50 of them basically said, do you have a virtual option? No, thank you. Like right after that, when we said no. And we really stuck to our guns. I really questioned it a lot during the process. I was like, man, we're losing out on these great applicants. But ultimately, these are great applicants for everyone they're applying to. And if they're able to interview online for 30 programs, it's easy. I guess the cost on their end is much lower. And people talk about bias for and against, but I mean, we really we decided to really commit to that, and we did, and I think it paid off. So we filled our 8 residency spots.
Yeah, so that's super huge. I mean, I was very happy to hear that when you announced it wherever. But yeah, I just the program I went to was a rural family program, and we had to go through this SOAP process, which is like you do basically, I don't know. Do you want to explain the SOAP process? So
if you don't fill, sorry, you get notification on Monday morning saying that you filled or you didn't fill. If I didn't fill, let's say I only got 6 of the 8 spots, so I have 2 spots that I have to fill, and you get this really awkward sprint where students find out Monday. Tuesday, they can apply to your program if they see that you have openings and they're interested. And then you're like doing this sprint of interviews, trying to get on phone calls with these people who are also being kind of attacked, if you will, by phone calls from people around them from other programs. And it's just like this, like a release of spots. We get to rank, I interviewed these 7 and I put them in order for my 2 spots. And then I find out an hour later if I got someone or not. And then we do it again, rinse and repeat the process. It's really a very high stress kind of, and you don't really know what you're getting, or I guess less so, because you can have someone who maybe didn't match into plastic surgery and decide that they want to take your spot. And on paper, that plastic surgery applicant is probably fantastic, right? All the board scores, all the grades, strong letters. But, that plastic surgeon may leave you after a year and may decide to reapply to plastic surgery the following year. So you're balancing all these risks and trying to say, okay, well, do we shoot for the top of the pile on the application list, or do we kind of go somewhere in the middle? Maybe someone that I don't know, peds or OB, and they were like maybe closer to family medicine interest rather than the subspecialized ENT who didn't match. So it's a high stress situation for both the students and the programs. Yeah, that's a whole other conversation too. Prepare the child for the road, not the road for the child. And I actually got to meet the author of this book, and really fantastic, very nice guy. But the idea is now we have to prepare the residents, right? So now we have to build them up to be able to get out and do the things. Rami asked a question, do you know what the national average for spot applications per spot? I don't know, actually, Rami. It's probably something we can find, though. It's probably not like super hidden.
I'm just curious. It sounds, 1,000 applications for 8 spots sounds really good to me. That seems like pretty stellar interest.
Yeah,
so
I think for a new program, I honestly, Tampa really sold it. Tampa General being a big place and living in sunny Florida was like a good selling point for us, being part of a big institution. So yeah, I do think that's pretty standard though, like that rate. And especially with online interviewing, people just apply broadly, and it's so easy to just apply to a bunch of programs. So how are we going to get them to where they need to be? And, hopefully we'll wrap up in the next 5 minutes so we can talk a little bit more. But we started with kind of some basics, and there are a lot of this, of what you see, I have to have in here. I have to have some experience of it on the schedule. And you'll see the intern year, the PGY 1 year, is very heavy on inpatient stuff. And as they go through the 3 years, they're doing much more outpatient stuff. And some things that kind of set us apart in one way, because you look at the 800 family programs in the country, and everyone is going to have its flavor in one way or another. But community health, we really wanted to make sure that there's a community health block every year. So all 3 years, there's a block of community health. And this is really where my hope is for them to get to know those zip codes that are around us, going to the free clinics in the area, serving the free clinics in the area, going to food drives for groceries to kind of see the food desert impacted patients, and doing health screenings at those places. There's a university area kind of nonprofit that we're working with to do those things, and hopefully recruiting from them and bringing them to clinics so they can help take care of them for whatever it is that they're going through. Quality improvement is a big push for us, and kind of the desire for our residents to have full control of their panel. So when they show up, they're going to have 100 patients. Really, that I'm donating, bittersweet as a clinician, to donate my continuity panel to the residents, and they will be able to see kind of through a lot of the reporting structure in Epic how their population is doing overall. What is my average A1C? And I hope in the future to get utilization data for them, like how often am I ordering CT scans compared to my colleague or compared to the attending? Am I quick to order CTs, or am I more judicious with my ordering schemes? And then we added this clinic management in the PGY 3 year. And this is a place where hopefully maybe these residents can do some sort of XPC fellowship, rotation, elective work in some way, but that's an opportunity for them to get an idea of what is out there. And my hope is for them to visit a value-based practice, to visit a DPC sort of practice, and to see what are the other ways people are doing primary care besides academic family medicine tailored for this community that we're in.
You said it. I didn't mean to cue you up.
No need. No, it's an interest. It's a really important thing so they can see what innovations are taking place nationally. Our curriculum, teaching wise, every Wednesday afternoon we have things, but we're doing things like with our pharmacists who also have a resident, pharmacy resident in their program. So there's collaborative teaching and working together in clinic with our pharmacy team. Reflective practice is kind of a flavor of what people might call M&M, but really the idea is, can you come on a case and show us where maybe things did not go as smoothly as you'd hoped? And that might be a systems-based problem. It might be a logistical thing. It might be a disparity thing. It might be a mistake and a learning point for the rest of the group. And then continuity clinic, we have these themes are repetitive throughout the year on the curriculum. We have an hour every month for continuity clinic so that we can learn what are those things that we need to have in mind for taking care of patients longitudinally. Of course, POCUS has become kind of the standard hip thing. I myself am not super POCUS trained or heavy, but one of our co-faculty did a fellowship in POCUS, and she's kind of leading the way here. But this helps with recruitment. For those of you that know or don't know, people want to be better diagnosticians, and having something in your hand that can tell you, help you delineate diagnoses is useful.
And Karim, if you go back, I know, one question is whether, like, where do you think AI falls into this? Like, will it ever be like POCUS? Because, we don't talk about the internet or electricity like as a separate thing. It's just part of our lives. And this is pretty transformational technology. And I'm curious, you have the medical education and AI Substack, which is which is probably just like, you're like, hey, go read my stuff. This is the residence curriculum that you would say to them. How do you think about the AI as a concept fitting into thing, or is it sprinkled into everything?
I hope it's involved in everything. I don't think you can separate it out from things anymore. When we talk about Journal Club, naturally they're using AI to review their journal articles. And when you talk about bradyarrhythmias and EKG interpretation, they're probably going to use AI to interpret EKGs at some point. So I don't think you can separate it from any of these topics, really. I think it's important, though, that we equip our residents to be able to use it well, and our faculty to teach with it, so that folks are aware of what's going on. But regarding POCUS, I don't have my butterfly with me in the room right now, but it is using AI when you're asking it to check a bladder volume of the bladder, or to gauge an EF. It's estimating based on some algorithm or some machine learning tool that it's been tuned to. So all of these things I hope to have, and I'll show you on the next slide. So we have different tracks, and I hope that our tracks, specifically the one in clinical informatics, is going to be utilized by residents. We hope that they pick by the end of their first year, and then they'll use their 6 months of elective time to really dive into these in a more detailed way. The MBA and the MPH track are really cool opportunities to do a fourth year. It's a 3-year program, but they're able to stick around and finish their degree. Even if they want to do like a global health thing and go abroad for some time, because of where we are, we have the ability to house them as kind of junior faculty, 4th year residents, or fellows, if you want to call them that. But our clinical informatics track is going to be aligned with our informatics fellowship program that's here in Tampa, and hoping to maybe do some work with the Cancer Center or with Tampa General, so that these residents can be aware of opportunities for doing a fellowship maybe in the future, or at least job opportunities that lean into the informatics space. So lots of potential on the tracks. We talked about most of these things: EMR optimization, data analysis, and QI, the XPC fellowship pathway. Maybe we're just flooding Polyus with residents year in and year out. Essentially, we need to differentiate ourselves by the things that we have on our faculty, what our interests are for our faculty, and what our goals are. Shoaib said, have you had your first class go into private practice or DPC? So I have not. They start in July, so July 1 is our first class. They're starting here in July. So you ask yourself, well, what are the absolute essential competencies that family medicine doctors need? And these are some areas that maybe we can talk about. We've kind of touched on each of them a little bit, one way or another. But these are from the American Board of Family Medicine. I have to sign off on these competencies for them to sit for their board exam. And my goal is not to go through this slide, but it's to show you that there's such a wide range of things. And Paulius, when we were going through training, these were not a thing yet. These are newer. So these are now asked of by the American board that the program director signs off saying, yes, so-and-so can do these things. It's everything from pregnancy and breastfeeding to end-of-life care and everything in between. So there's a lot of medicine. And I'm tempted to teach about different things in our curriculum, but something has to give. And we have to be careful not to swing the pendulum so far on the, innovation side of things. Not that that's bad, but we don't want to miss these things too. And it's really important for them to be competent clinicians so they could be useful for their health system in those innovation type conversations. But I just wanted to show you kind of the wide range of things that our trainees are expected to learn. One of my favorite quotes from Lord of the Rings, if going out your front door and you step on the road, and if you don't keep your feet, there's no knowing where you might be swept off to. And when I signed up for this job, I didn't know that I would end up here. Like when I signed on at USF, I actually didn't think that I would stick around very long. I thought it was like a step in between residency and what I'm finding next. But these are from you all in the RSVP and some other places online. Like, what is it that people are predicting? The integration of meta glasses, I think, is such a cool idea. Teaching things in the curriculum about AI scribes and diagnostics and CDS, personalized learning paths. Should people finish faster or finish later if they met the competencies already, or if they didn't meet them yet? Should they stick around for a longer time? And this is revolving around the competency-based medical education, which is a very common conversation now. And then, interprofessional training models and seeing the other side of medicine, I think are really important. But all of these things we're going to try to do in some degree. The meta glasses thing was a fantastic suggestion. My friend works in IT, and the IT like senior techs are now sitting behind their computer screen, and they're sending out the more junior guys to go solve the problem. And when they can't figure it out, they're wearing the meta glasses, and the other guys can just see what they're seeing and tell them what to do to fix the problem. And I see us doing a little bit of that in our assessment of learners. I actually pitched this to the ABFM because I think the way we assess doctors is pretty crummy with multiple choice questions. And I think we need to do something that's a little bit more live. And I know the ACP, I don't know if Matt is on here, the ACP is kind of thinking about doing that as well with their clinicians. And I saw this online and I thought it was funny. It was on a post that Paulius put in. So there are things coming, and hopefully we kind of touched on these. I would love to kind of open it up. I'm sorry we went a little over on time, but this is the QR code will lead you to my newsletter if you're interested, and happy to kind of chat and about anything teaching GME innovation and clinical informatics stuff on a later point. If you want to reach out to me, I'd be honored to kind of connect with you all individually. My final thought is that each of us on this call, or those people that you meet with, everyone is trying to do something good ultimately, right? And if we can do small things with great love together, we can do something wonderful. And I hope that you all appreciate this conversation, my journey, and thank you for the opportunity to just kind of chat with you all. Any questions?
This is amazing. Thanks for putting it together. So questions will follow for sure, at least for me. If you guys can flip your camera on, I guess maybe Dr. Freedy, Shoaib. I don't know. It's hard to get used to calling you by your first name, because actually the funny story is he was my attending in residency, and now we're like friends. It's kind of crazy. Life goes on. Okay, well, I'm gonna snap a photo for yearbooks. Okay, awesome. Thanks, guys. So yeah, we have maybe let's give people 5 minutes for hanging out, and then we can finish 5 minutes early. And I'll stop the recording in case people want to get spicy.